Assalamu alaikum. On behalf of Ahsan Academy, let me welcome you to a presentation on pericardium. Let us first fix the learning objectives. We'll first discuss the gross appearance of the pericardium, then its detailed distribution as well as the structure of the pericardium, and at every stage I'll try to correlate clinically. Pericardium is the coverings of the heart and a part of the great vessels that is close to the heart. It is a combination of fibrous pericardium as well as serous pericardium. So fibrous pericardium is in the outer part, and serous cardium is close to the heart. Let us see this small blocked area. You can see the heart muscles and heart cavity below and to the left, and coverings on the upper, above and to the right. Is a label part. This is the layer of the serous pericardium that tightly adheres to the heart muscles, and then it is reflected as shown by the arrow and forms the parietal layer that is very close to the outer fibrous coat, and in between there is space between the parietal and visceral layer. The total covering is very thick. So pericardium has two components, and if we count the layer, there are three layers. So the fibrous pericardium is single layer and is very tough external covering. The serous pericardium is relatively thinner and glistening two layers membrane. The parietal layer is the outer and the visceral layer is the inner. That visceral layer is in direct contact with the cardiac muscles. If we consider the development, let us see one example. This is supposed to be a balloon containing some fluid. So if we place some solid organ inside this, so how does it looks like? It will looking like something is going inside the cavity. So this will take some part of the membrane with the organ. This and other parts will remain away and separated by the cavity. The outer part that covers the outer layer of the organ is the visceral layer. Then it reflects and remain away from the organ, and it is parietal layer, and in between there will be a cavity. If development continues, then outer part condense to form the fibrous pericardium. Now the fibrous pericardium is relatively tough, so this will not expand too much as rapidly the organ expands. So what will happen, the cavity will reduce in size and the organ will enlarge gradually and take the visceral layer with the organ. The gap between the visceral layer and the parietal layer will be reduced gradually. You see, this is heart is enlarging, the fibrous pericardium is there, single layer, thick connective tissue coat, and this heart is covered by the two layers of pericardium, and thin cavity is there as a potential space between visceral and parietal. So fibrous pericardium is about 1 to 2 millimeter thick connective tissue covering, and this is dense connective tissue, and it is continuous superiorly with the outer layer of the great vessels that opens or arises from the heart, and inferiorly the fibrous pericardium is continuous with the diaphragm. It is the central tendon of the margin of the central tendon. It becomes fixed with the central tendon. Phrenic neurovascular bundle descends between this fibrous pericardium and the pleura by the side. The area superficial to this pericardium is just a small area at the behind the lower half of the body of the sternum. I am showing by that arrow on the figure. This is the lower part of the body of the sternum, and sternal end of left fourth and fifth costal cartilages overlies the uh, part of the heart covered with the pericardiums. So this pericardium heart is directly in contact with this part of the thoracic wall. So if we tap with the finger, this is known as percussion. If we place one finger and tap with the other finger of the other hand, then there will be sound that is no relatively dull sound in the over the lung, as because of the presence of the air the sound will be resonant. So the anterior thoracic wall mainly most of the area shows resonant on percussion, but this area, the small area, will be dull because of the presence of heart. And in this way the doctor can outline the position of the heart, and this area is known as superficial area of the superficial cardiac dullness. Serous pericardium is bilayered, and already we have discussed how it develops. We can compare it with a balloon, and the fist is going inside the balloon. So one layer of the balloon will be in direct contact with the fist, and the content of the balloon will separate another layer, that is parietal layer, and both the layers will be continuous at one point. This is the point of reflection. So this is very closely lie between the fibrous pericardium and the cardiac muscles. The outer layer is the parietal layer, which is in contact with the fibrous pericardium. So this is forming the inner surface of the fibrous pericardium. The visceral layer lines the outer wall, outer surface of the heart, and forms a layer of the heart wall, and this is known as epicardium. So we cannot separate without injuring the outer layer of the heart. This also continues with the blood vessels that is remaining attached to the heart as outer layer, and it is called the adventitia of the blood vessels. Then it reflects to form the parietal layer. Its continuity with the parietal layer at the margin. This is composed of an epithelium inside. This is ciliated columnar epithelium, also known as mesothelium, and it produces as well as reabsorbs the fluid present inside the potential space, and a thin connective tissue layer with large amount of elastic fibers outlines the epithelial cells. The cavity of the serous pericardium is a potential space that contains small amount of fluid, amounting 15 to 20 ml in normal condition. This is forming a thin slippery fluid that reduces the friction between the two layers, parietal layer and visceral layer. Because of the complex development of the heart, the reflection point where the visceral layer become parietal layer makes some hidden spaces. These are known as sinuses. Let us say if the heart was parallel tube and pericardium was the covering, it first folds, then make a twisting, so there will be a reflection. At the point of reflection there is spaces, and these spaces are known as sinuses. Let us discuss sinuses in detail. One is the transverse sinus. You can see the finger is placed in the transverse sinus of the pericardium. It is just above the superior border of the heart and formed between the aorta and the pulmonary trunk. So you can see the base from the behind on the right figure. You can see the pericardium, fibrous pericardium, after removal of the heart in the middle figure. So this one is the pulmonary trunk and this one is the aorta. One side these two structures are there, and behind that the superior vena cava, and this is SVC, means superior vena cava, and these are four pulmonary veins. So in between there is arrow, red arrow is indicating a space. This space is known as transverse pericardial sinus. You can see in the middle figure one arrow, a red arrow is coming, and yellow tint is there in the transverse sinus. This area is clinically important for the cardiac surgeons. Oblique sinus is formed. You can see the figure, heart is removed. Behind the base of the heart, these structures are present: the pericardium, fibrous pericardium, and the blood vessels. So inferior vena cava and four pulmonary veins makes a hidden space. This is the oblique sinus. Let us label it. If you raise the inferior surface of the heart and you see from below, you can see this oblique sinus indicated by the blue arrow on the left figure and the blue arrow in the middle figure and the black arrow in the right figure. So it is bounded between, this is the inferior vena cava and these are the four pulmonary veins. So this is guarded by this pericardium secures the intrathoracic cardiac stability. That's why it is known as cardiac seat belt. It's superiorly, the pericardium, especially the fibrous pericardium, is continuous with the outer covering of the blood vessels who are fixed to the wall, and inferiorly this fibrous pericardium is continuous with the central tendon of the diaphragm. So anteriorly, the fibrous pericardium is attached to the posterior sternal surface by the sternopericardial ligaments. This pericardia reduces the friction between the heart and the mediastinal structure because of the thin film of fluid between the serous and pericardium, means between parietal and visceral layer of the serous. The pericardium limits the distension of the heart and over dilatation of the chambers. So it prevents a hypertrophy, means enlargement of the heart. Pericardial cavity maintains the hydrostatic pressure and prevents the ventriculoatrial regurgitation, means backflow. This is barrier to the spread of infection and facilitates atrial filling by promoting the negative pericardial pressure. The pericardium is mostly supplied by right and left internal thoracic artery. This artery gives the pericardiacophrenic branch and that supplies the pericardium. This is also receiving minor supply from intercostal and superior phrenic arteries and mediastinal branch from the descending thoracic aorta. Veins are drained mainly into the azygos vein and also internal thoracic and superior sensory nerve supply. The pain from the parietal pericardium and the fibrous pericardium passes through the phrenic nerve. So this phrenic nerve is formed by the cervical third, fourth, and fifth spinal nerve ventral rami. So the referred pain will be deflected on this dermatome area. The pain from the serous pericardium runs via the sympathetic fibers of the heart. The vagus nerve supplies the parasympathetic through the esophageal plexus and through the left recurrent laryngeal nerve. The pain for the pericardium arising from the pericardium is very sharp, sudden in origin, severe, and felt just under the sternum. It is called substernal pain. It is increased when the person lean back and lean to the left side, and it is reduced by leaning forward. So patient usually try to feel some comfort by leaning forward and showing that the pain is severe in the central part of the lower part of the sternum. Thank you very much for remaining with the presentation.